Welcome to the Medical Report. We're pleased to have with us as a return guest Dr. Simmons, who is an orthopedic surgeon at Chester County Hospital. He belongs to the group known as Premier Orthopedic and Sports Medicine of Chester County Orthopedic Associates. So we welcome you back.
Thanks for having me.
Yeah. One of the reasons we're asking him back is our topic today is going to be knee and hip replacement surgery. And there have been some innovations and changes that have occurred since his original presentation. So we look forward to hearing what some of those are. I think we ought to start first with the hip, and I'd like to ask you how you evaluate a patient. We'll start with the knee. How do you evaluate a patient for knee replacement?
Well, most patients with knee problems have had them for quite a while, and it may have started with an injury in their youth, and by the time they see us, often they've had quite a bit of treatment. That treatment can include activity modification, oral medicines like ibuprofen and naproxen. Some people are treated early on in the disease with injections such as cortisone and even lubricating medicines. When they get to the point where they're considering a replacement, they typically have quite a bit of pain, they have limitation of motion, they often have discomfort at night, they have difficulty doing their activities of daily living like climbing stairs, going to the market. And I tell patients that the reason to have a knee replacement primarily is pain and secondarily limitation of function. We see plenty of people that have an x-ray that looks bad, that shows a worn knee, but they don't necessarily have to have a replacement until they meet the criteria of pain and limitation of function.
Are there any modifications or nuances in knee replacement now that weren't present perhaps when you last spoke?
Well, it's constantly evolving. It's a very technical procedure. No matter how you do it, it's still a big operation, and people have to understand that there's a big commitment of time and effort in recovery. The implants that are used to replace the knee are constantly evolving and improving. We used to worry much more about loosening and wear of the implant. Today, the implants are designed such that they can last for decades and not need to be revised again. Many people envision that they're going to have their knee removed and a hinge put into their joint. And I try to reassure people that that's not really what happens. It's more of a resurfacing. And I actually have a model of an implant here. So basically, we're putting a cap on the end of the bone below and above that makes the joint smooth again. And that has a plastic bearing that acts as the new cartilage. The patient still has most of their own bone. They have their own ligaments and even their own kneecap that articulates with that. So a total knee replacement is basically a resurfacing of the joint to give it a smooth gliding function again.
What is the material made of?
The metallic portion is a fancy stainless steel chrome cobalt alloy. And then the bearing is made of a high-density polyethylene plastic that acts as the cartilage.
Now, I've heard that there is a possibility for some patients that they can have a partial knee replacement.
That's correct. In my practice, about 10 or 15% of the patients are candidates for a partial replacement. If you think of the knee, there are really three compartments to the knee. There's the outside, the inside, and the kneecap joint. Most people that have arthritis in all three areas, and they require a full replacement. But some patients had a cartilage taken out when they were younger from a football injury, and they only have arthritis in one part of the knee. And if that's the case, we can often do a partial replacement where we just resurface the part that's damaged and we leave the other parts, the outer side and the kneecap, alone. And this is a lot less invasive. It feels a lot more natural, like a regular knee, and lets people get back to their activities quicker.
How do you decide whether the patient is a candidate for a partial knee?
Well, we use a combination of factors. We, of course, look at the x-ray and see where the arthritis is and the disease is. But the biggest thing that I do is listen to the patient's complaints. If they can take a finger and point to one area of the knee where they hurt, and that area matches up with the damage on the x-ray, then they're likely to be a candidate for a partial replacement. The patient that grabs their whole knee and says, "I hurt all over," is usually not a candidate. And at the time of surgery, when we look inside the knee, we inspect the other parts of the joint. I tell my patients that there's a chance that when we open it up, if the rest of the knee is damaged, we may have to go ahead and do a full replacement. But that's rare. Most of the time we know ahead of time what we're going to be able to do, and we can accomplish it.
Without getting too technical, could you kind of explain how you do this?
Yeah. Well, no matter how you do it, there is a little bit of carpentry involved. And you hear commercials and ads for minimally invasive replacement. And that's kind of a misnomer, because we're putting in big metal parts, and you've got to be able to see, and you've got to be able to open the knee up and able to fit those in and do the carpentry correctly. If it's not done correctly, then the knee may be unstable and loose and not function the way it should. So basically, we open the knee up and slide the kneecap out of the way so we can see. We remove the diseased portion of the knee and then put these caps on and close everything up. And it's done in such a way that the patients can put weight on it immediately and begin to bend immediately, so they're not in a brace or a cast when we start the rehabilitation the same day.
Should we admonish the wood shop people not to try this?
That's correct.
Now what is your anticipated recovery for knee surgery?
Typically, that's something that's changed quite a bit recently. The rehabilitation is accelerated now. If someone has surgery, for example, on a Monday morning, Monday afternoon we have the patient out of bed, they walk across the room and they sit in a chair and start doing some exercises. Most people are in the hospital for about 2 days, and before they leave the hospital, they're able to go up and down steps, get in and out of a simulated car, and usually go home. So most people do not have to go to a rehabilitation facility. At this point, we set up for home services for them to come in and work with the patient in their own home, and they're much more comfortable.
And how is the pain management with this?
Well, knee replacement is a tough operation, and that's one of the struggles that we have, even more so than hip replacement. And recently we've learned that it's much better to treat the pain ahead of time and get ahead of that, and to use a combination of different pain medications rather than slugging the patient with morphine and making them ill and itchy and so forth. So in our protocol, we give patients several different medicines before the surgery even starts. And we found that by blocking the pain pathways in the nerves ahead of time before the surgery occurs can really cut down on the pain afterward. So we'll give people anti-inflammatory medicine, Tylenol, acetaminophen, all the things that work in different ways, some nerve blocking agents, and that way they need less narcotics and they feel better after the operation.
Now, during the rehab part of this, I'm sure there's some discomfort.
There certainly is, and again, so going on with that pain management, we hit the patient ahead of time to try and head it off at the pass. During surgery, we block the area with Novocaine medication, long-acting Novocaine, so that when they wake up from the surgery, they don't say, "Wow, I just had a replacement." They can actually function and do some therapy early on. And then post-operatively, we continue this combination of medicines to try to avoid a lot of narcotics, because those are the medicines that give the most side effects.
Right.
But patients do need pain medicine, usually for a few weeks. It tapers down over time. And typically, within a couple of weeks, they're walking with a cane. It takes about 2 or 3 months to fully recover.
That was going to be my next question. What is the anticipated length of recovery?
I warn my patients that you won't be happy with me in the first 10 to 14 days, but by 2 to 3 months, if you stick with the program, you'll be happy.
Well, this is Just out of curiosity, how many knee replacements do you do on average?
I personally do over 200 hip and knee replacements a year, and that's built up certainly over the years as my practice has matured. Mm-hmm. And it really does make a difference to have that kind of experience, I think. It's been shown in studies that if you do less than 10 or 15 a year, then there's a chance you're not going to be doing the procedure as well. Yeah. So practice does help.
So that's the old idiom, practice makes perfect, I guess. And I think this is an important concept that particularly in the surgical field anyhow, where you have to do a technical thing that someone is trained and experienced. And oftentimes people will ask me for a referral, and I'll say, look up the volume first, and then we'll talk about it.
I think that matters.
Yeah, it does matter. Okay. Are there any things I haven't asked you that you would like to discuss about that?
Well, I think we've covered. Just briefly getting back to the prosthesis, you asked about technical improvements.
Yes.
The weak link in most of these joint replacements is the plastic bearing. And traditionally, the plastic would wear out in 10 or 15 years. That's what my patients always tell me. Well, I hear it's only going to last 10 or 15 years. Today, the plastic has been improved such that we expect to get, hopefully, decades of wear. The parts can come loose from the bone, other things can happen, but the plastic is markedly improved, and that was really the weak link that we feel is going to add to longevity.
Mm-hmm. Are there any tools or special pieces of equipment that permit alignment, proper alignment?
There are, and there's been a lot of research in that vein, and I have experimented with some of these computer-guided alignment systems. There are robots that do part of the surgery for you. None of those have really made it to be prime time yet. They haven't been proven to be better than the traditional hand instruments. I think 5-10 years from now, I'll bet you most of these will be done using some type of computer guidance. Mm-hmm. But in my mind, it hasn't surpassed the traditional way yet.
Right. So has anybody attempted, is there any place for robot surgery in this at all?
Well, as I said, there is, particularly with the partial knee replacement. There is a robotic system that basically guides the surgeon's hand in doing some of the carpentry. Okay. And helps to align the knee properly. But it's very expensive, and it has not been shown to lead to better outcomes yet. As I said, I think they're perfecting this technique, and within the next few years, we'll probably all be doing it that way.
Okay. Well, I think we've gotten a pretty good overview of some knee replacement, and we're going to discuss next hip replacement. So if you stay with us a bit, we'll open up with that discussion in a few minutes. Welcome back to the Medical Report. We have with us Dr. Chet Simmons of Prima Orthopedics and Sports Medicine, Chester County Orthopedics. We have just completed our first session on knee replacement, and there was one question that I did not ask, I failed to ask, that I think we ought to bring out, and that is how do you decide what size of prosthesis to use?
Well, that's another big improvement in the last 5 to 10 years. Previously, there were only a few sizes of implants, and we would have to make the size fit the patient, and sometimes you would have to compromise, and the knee would be a little big or a little small. If it's too big, it can overstuff the knee and make it feel stiff and not move properly. But all the companies that make these implants have recognized that, and in the last few years, many more sizes are available, and the implant has been contoured to fit the bone better, particularly women. Women's bones tend to be a little bit narrower than men's bones. And so the implants are now designed to fit both women and men appropriately, and we don't have as big a problem with that.
That's good. Okay, so we're going to move on now to the discussion of hip replacement. And once again, we're going to ask Dr. Simmons how you evaluate a patient to to determine whether they need hip replacement?
Well, it's interesting. Hip patients tend to be a little more difficult to diagnose sometimes. They don't always recognize that they have a hip problem. Many people come in and think they have a sore back, or they may have thigh and knee pain that they don't recognize as coming from their hip. So the classic hip patient has pain in the hip that radiates into the groin and thigh, and they have limitation of motion of their hip. They find it's difficult to put their shoes and socks on. They have trouble bending their knee up because the hip is stiff. So an examination can really help ferret that out. And then, of course, we get x-rays, and if we see that the ball and socket space is narrowing, that the cartilage is wearing down, we can tell that they've developed arthritis of the hip.
And so, and very frequently this is one-sided?
It often is. Many people have arthritis in one hip and not the other. And they're not doomed to develop arthritis in the opposite hip. Some patients, as you know, with systemic arthritis, like rheumatoid arthritis, tend to have a more symmetrical pattern of arthritis, but the typical wear and tear osteoarthritis may be one-sided.
And I assume from the anatomy of the hip, there's no such thing as a partial hip replacement.
No, there really is not. We'll do that in a fracture. If someone falls and breaks their hip and they basically break the ball off the femur and their socket is normal, we can put in a partial hip that has a swiveling socket and maintain their own socket. But for most people with arthritis, the joint is damaged on both sides.
Okay. Now, can you describe anything what is new in hip surgery?
Well, much like with the knee, the implants are greatly improved. With a hip replacement, we're putting a stem into the thigh bone that replaces the ball, and we put a socket up into the pelvis that has a new bearing surface that makes it smooth and gliding. And the surface is again made of a polyethylene plastic. In the hip, we can use a metal ball or a ceramic ball. The ceramic ball sounds like it would be brittle, but it's actually a special ceramic that's very durable. You could hit it with a golf club and it wouldn't break. And it's slightly smoother than metal, so there's a little bit less friction on the plastic, and that can lead to longer wear. So the implants are much improved in hip replacement as well as knee replacement. And I don't worry too much about people wearing out their hip like we used to, because the wear properties are so good now. The other big advancement, I think, in hip replacement is the surgical approach that we use. The traditional hip replacement was done either from the side or from the back of the hip, and it requires detachment of muscles and repair. And that can lead to a longer recovery as the muscles heal. In the last 5 or 6 years, I've converted much of my practice to a newer approach where we approach the hip from the front, and we actually work in a window between the muscles and do our carpentry work without detaching or repairing anything. And I found that it leads to a much quicker recovery.
That's very interesting. Does it take any longer to do it that way? Or not?
It does not. It takes some special training and experience, and I did a lot of training both with live surgery, cadaver surgery, models, and over a period of years switched my practice to be able to do it. You can't do it in everybody. There are some people that are morbidly obese or extremely muscular that you just can't get to the site that way. But about 95% of my patients are candidates for it now.
Does this speed up the recovery time?
It really does in my experience. A typical hip replacement patient with the older method is on crutches or a walker for 3 or 4 weeks. And with this newer method, because the muscles aren't disturbed, many of them are walking with a cane within a week. And by 3 or 4 weeks, they're walking pretty comfortably without any assistive device. So all the milestones of therapy are pushed up by a couple of weeks this way.
Now, once again, we're talking about recovery. What is the average length of time that a person say everything goes well and there's no complications, that person will be back to full ambulation?
I think with a hip replacement, it's usually a little bit quicker. And if you talk to people that have had a knee and a hip done, almost all of them say that the hip was easier.
Yeah.
It's not as painful. There's not quite as much intensive therapy. And with this newer approach that I've been using, it's really not unusual for people to be walking without any kind of a cane or a crutch in 3 or 4 weeks. And many people that work in an office setting are back to work in 3 or 4 weeks. It takes a couple months to fully recover and get all the strength and balance back.
Now tell us a little bit about pain management with this group of people.
Well, we use the same principles. Again, the hip replacements tend to be not quite as painful, and they don't have to have a therapist cranking on their knee to bend it right away, so the hip seems to heal kind of naturally on its own without intensive therapy. But we use the same principles of this. We try to attack the pain before it happens and block those pain receptors with medications before the surgical insult occurs. And we use the same type of medicines, anti-inflammatories and analgesics going forward. We'll also inject the hip with a cocktail of Novocaine type medication to help numb it for hours after the surgery and give a smoother transition from the operating room to the patient's room. But in general, they're more comfortable.
Now, everybody will ask a question that what are the downsides of these? Are there any complications to either of these procedures that you talked about that are of great significance?
You bet. These are big operations, and I caution people that there are complications. The big complications that we worry about are infection, of course, bleeding, blood clots. And those are all very rare, but if you get one of those, that's a big deal. And there are a lot of things that we do to help prevent them. We operate in special space suits that isolate us from the patient in the operating room to help prevent infection. Patients are given antibiotics before and after the surgery. And then most patients are put on some type of a blood thinner for about a month. Traditionally, we use strong blood thinners like Coumadin and heparin, and we found that many of those can cause undesirable bleeding complications. So today, most patients are simply given aspirin for about a month after surgery, and that does a good job of preventing most serious blood clots.
From day one?
From day one. So those are the big issues. It's rare for people to have enough bleeding to require a transfusion, and we don't typically ask people to donate their blood ahead of time because statistically it's not been shown to make a difference.
That was an old way. Everybody did it years ago.
That's correct. Yeah, it was. We found out most of that blood would end up getting wasted.
Yes.
So it's not done anymore.
Yep. Now, in the recovery, the rehabilitation of either knees or hips, do you have these people go to like a rehab center for outpatient, or do you have most of the time, can they send therapists to the house?
Initially, the therapist will come to the house. So for the first couple of weeks, before the patient's comfortable getting in the car and going to a therapy center, they'll come to the house. Usually by 2 or 3 weeks, most patients are mobile enough that they can get in the car and go to a therapy center for 2 or 3 days a week and get that therapy done as an outpatient. That's
good. And I assume, and lots of people will ask, are all these procedures usually covered by insurances?
They typically are, yes. These are not cosmetic procedures. They're medically necessary, and they're usually covered well.
That's good. Well, I think we have a pretty good idea now of joint replacements and what's new, and we certainly appreciate your time and coming down and discussing it with us.
My pleasure. Thanks for having me.
Thank you for coming.